Good afternoon, everyone. We're going to go ahead and get started. For those of you who don't know much about this GoToWebinar, you can actually type questions throughout the presentation. So feel free to type those as they come up, and I will answer them as I see them. Thank you for joining us on this webinar over the 2014 Evidence-Based Guidelines in the Management of High Blood Pressure in Adults. My name is Sara Richter, and I'm an assistant professor of pharmacy practice here at the college, and actually a 2012 graduate of the college as well. And currently I practice in internal medicine at Barnes-Jewish Hospital. The purpose of today's webinar is going to be to review the 2014 recommendations made by JNC 8, compare and contrast JNC 8 with JNC 7 recommendations, and lastly to discuss the limitations of the 2014 JNC 8 guidelines. These guidelines really do represent the first update in 10 years to the hypertension guidelines. JNC 7 was published in 2003, so again, the first update in 10 years. And this guideline, instead of seeking to be a comprehensive guideline, really set out just to answer three specific questions. First, does initiating antihypertensive therapy at specific thresholds improve outcomes? Second, does treatment with antihypertensive therapy to a specific goal improve outcomes? And third, do various antihypertensive drugs or drug classes differ in benefits and harms on these specific outcomes? And as you can see by looking at these questions, the focus was really on pharmacologic treatment and blood pressure goals rather than at other aspects such as non-pharmacologic therapy and definitions. Before looking at the individual recommendations made in the guideline, I think it's important to note the grading system that was used by the panel. And as you can see in this table, grades A through C range from high certainty of substantial net benefit with grade A to moderate certainty of a small net benefit with grade C. Grade D, which is actually not used in these guidelines, would represent a recommendation against. And then the last one I want to note is grade E, which represents expert opinion. And what this means is that the panel really decided that there was insufficient evidence from randomized controlled trials, but as a committee they determined that this recommendation would be appropriate. Recommendations 1 through 5 focus on the treatment thresholds and blood pressure goals. And recommendation 1 focuses on patients of 60 years of age or older. And it states that we should initiate pharmacologic therapy if the systolic blood pressure is above 150 or the diastolic pressure is above 90, and this would be our goal as well. So a goal in patients over the age of 60 would be less than 150 over 90. And this is really based on evidence that suggests that this goal of less than 150 over 90 showed a decreased incidence of stroke, heart failure, and coronary heart disease. And there really wasn't any good quality evidence suggesting that a lower goal in this age group provided any additional benefit. So no trial is supporting a goal of less than 140 systolic compared to a goal of 140 to 149. And you'll see here that this recommendation does have a grade A, so a strong recommendation. But later on in the presentation, we're actually going to talk about some controversy surrounding this specific recommendation. Recommendation 2 looks at patients who are under the age of 60, and it states that we should initiate pharmacologic therapy with diastolic blood pressures greater than or equal to 90 and treat to a goal pressure of less than 90. This recommendation was actually based on 5 diastolic blood pressure trials that showed reductions in cerebrovascular events, heart failure, and overall mortality with this blood pressure goal of less than 90. And again, there were really no trials that showed any additional benefit of targeting a lower goal than this. So one trial the guidelines reference is the HOT trial, and in this trial they compared diastolic pressures of less than 90 to less than 85 and less than 80, and there was no added benefit of those lower diastolic blood pressure goals. Recommendation 3 looks at systolic blood pressure in patients under the age of 60, and this recommendation states that we should initiate therapy if the pressure is greater than or equal to 140 and treat to a goal of less than 140. This recommendation was based on the fact that the panel found insufficient evidence for a systolic blood pressure goal in this patient population. So that's why the diastolic blood pressure goal actually has a stronger recommendation than this systolic goal. And how they kind of came to this expert opinion for the systolic blood pressure goal was really based on 3 factors. First, they decided that if there's no evidence supporting a different goal than the previous guidelines. Let's not change it. So they stuck with kind of the JNC7 goal. Second, they said that in the trials for diastolic blood pressure, the patients who achieved diastolic blood pressures of less than 90 also tended to achieve systolic pressures of less than 140. So the panel couldn't really decide is the benefit from the diastolic pressure, the systolic pressure, or both. And their last kind of rationale was that if we're going to have goals for diabetes and CKD that are also less than 140 systolic, maybe it would make the guidelines easier to implement if this goal was the same. So that was kind of their three reasons for the rationale behind this expert opinion for systolic blood pressure goals in this patient population. Recommendation 4 focuses on blood pressure targets in patients with CKD. And you can see that the threshold here is again greater than 140 or greater than or equal to a diastolic of 90, with the goal being again less than 140 over 90. This recommendation was based on the fact that there really wasn't sufficient evidence supporting the previous goal of less than 130 over 80, so the more strict blood pressure goal in this patient population, which was used in JNC7. And the panel found some evidence showing that there was a benefit in regard to slowing progression of CKD with this more strict target. But again, they didn't really see any cardiovascular outcome benefit. So for that reason, the panel really decided that it was better to stick with a higher or less strict target of less than 140 over 90. Similarly to patients with CKD, the recommendation for diabetic patients also had the goal of less than 140 over 90. And again, this differs from JNC7, which had a more strict goal of less than 130 over 80. And this recommendation, again, kind of doesn't have the best evidence to support it. So there were trials showing cardiovascular mortality benefits with systolic blood pressures less than 150 in diabetic patient populations, but no specific trials actually compared systolic pressures of less than 140 to systolic pressures of less than 150. Therefore, that's why this recommendation is based on expert opinion. They really couldn't justify such a dramatic increase in the goal from the previous standard of less than 130. So they, again, kind of stuck with the less than 140 target with the idea that it would be easy to implement these guidelines if we stuck with similar targets for various subpopulations of patients. Recommendations 6 through 8 now shift from blood pressure goals and thresholds to antihypertensive treatment. So blood pressure 6 looked at non-Black patients, including those with diabetes, and laid out 4 initial drug therapy options. So thiazide-type diuretics, calcium channel blockers, ACE inhibitors, or angiotensin receptor blockers, or ARBs. And if you're familiar with the previous JNC7 guidelines, you'll notice that beta blockers is the drug class missing from this initial agent list. And the reason beta blockers were not recommended in these recommendations were because that they actually found one trial that showed an increased risk of the composite of cardiovascular death, MI, and stroke in patients being treated with beta blockers compared to patients on other antihypertensive therapies. And there were also other trials showing that there was not this associated risk with beta blockers. However, the panel felt strongly enough to eliminate them from the initial therapy options in this population. Recommendation 7 focuses on the Black patient population, including those with diabetes. And the recommendations here is that first-line options should consist of a thiazide-type diuretic or a calcium channel blocker. So you'll notice that ACE inhibitors and ARBs have been removed from the first-line agents in this patient population. This recommendation was really based on subgroup analysis from the ALL-HAT trial, and these analyses showed that thiazide diuretics compared to ACE inhibitors resulted in decreased incidence of stroke, heart failure, and cardiovascular outcomes in the Black patient subgroup. And additionally, ACE inhibitors showed an increased incidence of stroke compared to calcium channel blockers in these subgroup analyses as well. And then overall, ACE inhibitors were just shown to have a smaller effect on blood pressure compared to thiazides and calcium channel blockers. So for all of these reasons from the ALL-HAT trial, it was determined that these should be the first 2 agents in the Black patient population. Recommendation 8 is really the last recommendation focusing on therapy, and this looks at adult patients with chronic kidney disease. And it states that initial or add-on therapy in patients with CKD, regardless of age or diabetes status, should consist of an ACE inhibitor or an ARB. And this kind of contradicts the above recommendation, recommendation 7. So the question kind of comes up, what if we have a black patient with CKD? And the guidelines do have an expert opinion that state if you have a black patient with CKD who also has proteinuria, it's probably more beneficial to have an ACE inhibitor or ARB on board first. However, if you have a black patient with CKD that does not have protein in the urine, the ACE inhibitor or ARB can be delayed as an add-on therapy. And the thing with chronic kidney disease is that most of these patients are going to require more than one agent to treat their hypertension regardless, so you would likely be able to add on both of these agents. This algorithm is available in the guidelines and summarizes pretty much all of the recommendations we just talked about, so recommendations 1 through 8. And later on in the webinar, towards the end, we actually have some practice cases that will allow us to kind of work through this algorithm. The final recommendation provides insight on how to titrate medications to reach a blood pressure goal. And you can see that in general, they recommend maximizing initial therapy or adding on therapy from the list of preferred agents. So pick a preferred agent, titrate to the max dose, and then add another from the preferred list. So either a thiazide calcium channel blocker, ACE inhibitor, or ARB. They do note that we should avoid the ACE inhibitor and ARB combinations due to increased risk of poor safety profiles such as hyperkalemia and acute renal failure. And again, the algorithm presented in the guidelines summarizes this recommendation as well. So the final step you can see after we've titrated the max doses and added on from the preferred list would be to add additional classes of medications such as beta blockers and aldosterone antagonists, or refer the patient to a hypertensive specialist. We already discussed some of the differences between JNC7 and JNC8 during that recommendation part of the webinar. However, I do want to touch on key differences noted in the guidelines. The first is a difference in the goal of the guidelines. So JNC7, you can see, focused a lot of time on defining hypertension and working out different stages of hypertension in patients, while JNC8 really only made thresholds for treatment. So the biggest differences here are there's no definition. Instead, there's just at what blood pressure do we want to treat patients with hypertension. The second difference I want to point out is that the blood pressure goals have changed a bit since the previous guidelines in 2003. And the main differences, as you can see, focus on age. So previous guidelines did not have a different age cutoff for various goals. They just recommended a goal of less than 140 over 90 in the general population in JNC7, compared to a less strict goal in the elderly patients in JNC8. And also you can see that there are differences in goals for the comorbid conditions of diabetes and CKD. Third, JNC7 had 5 drug classes considered as initial therapy. We already briefly discussed this when we talked about beta blockers. And they broke down what treatments patients would receive based on what they called compelling indications. So if a patient did not have a compelling indication, the first line option was a thiazide type diuretic. And then if they had compelling indications, treatment was defined as you can see here on this slide. So if you remember, a lot of us in school learned the PharmD acronym. So P is previous stroke, H is heart failure, A was ACS, R was renal disease, M was maximum or high CVD risk, and D was diabetes. And this dictated what treatment therapies we would start first line. And you can see beta blockers and aldosterone antagonists had a specific place in therapy in JNC7. When we look at JNC8, there's only 4 drug classes considered as first-line therapy options, and instead of compelling indications, therapy was dictated by different subgroups, so based on race or the comorbid condition of chronic kidney disease. The final difference I want to point out between JNC8 and JNC7 is that late in the middle of 2013, when these guidelines were being put together, the National Heart, Lung, and Blood Institute, or NHLBI, actually decided that it was going to stop developing guidelines, including those already in progress, which would be JNC8. And they decided that they would rather partner with other organizations and they would write the guidelines and then those would be approved by the NHLBI. So what this meant for JNC 8 is that it would actually have to undergo further review by additional organizations, resulting in a longer time until publication. And the panel really didn't want to deal with this additional review process, and they wanted to get publication underway as soon as possible. So they elected to pursue publication independently, and for that reason, it's important to note that these guidelines are not sanctioned by the NHLBI. Before getting into the practice cases, I thought it would be important, again, just to emphasize that there are differences in treatment algorithms based on what guideline is being referenced. So you are going to see differences based on the type of patient and what area you're practicing in. So this table here, again, just summarizes the recommendations made by JNC 8. And then if we compare that to the European guidelines, so these guidelines are from the European Society of Hypertension and the European Society of Cardiology. And you can see that overall there are some similarities, but there are some differences as well. So the European guidelines also have a different blood pressure goal cutoff for their elderly patients. However, they have a pretty vague definition of what's considered elderly. And you can also see that they still include beta blockers as an initial line of therapy. Additionally, they have a lower diastolic blood pressure goal for patients with diabetes, based on some previous literature that was not utilized in JNC 8. And then also they have some differences in blood pressure goals based on the presence of proteinuria in patients with CKD. The next guideline I'm going to compare is the Canadian Hypertension Education Program guidelines that were published in 2013. Again, pretty similar to JNC 8. However, their elderly cutoff, or their cutoff in age for the different blood pressure targets, is actually 80 years old, and we'll talk about why that might be in a few slides when we talk about the controversy surrounding that first recommendation. You'll also note that their diabetes recommendation sticks to the previous JNC 7 goal of less than 130 over 80. So again, sticking with a more strict target in those diabetic patients. Next are two guidelines that we are probably all pretty familiar with, so the American Diabetes Association and the Kidney Foundation guidelines. And you can see overall pretty similar, but the ADA actually recommends a lower diastolic blood pressure target in diabetic patients. And then the Kidney Foundation breaks up their blood pressure goals, again, based on the presence of proteinuria. So more detail with those guidelines compared to JNC 8. So if you see different goals being referenced, the important thing to note is just to take into account what guidelines the clinician is referring to. All right, so now we will get to some practice cases. So the first case looks at a 62-year-old African-American male with a past medical history of diabetes and hyperlipidemia, and he's presenting to the clinic for follow-up. And he has been taking his blood pressures at home over the past month, and they've been ranging in the 140s over 80s. And he wants to know, is pharmacologic therapy appropriate at this time, and if so, what therapy would be recommended? So again, this is the algorithm provided in the guidelines, and we're just going to walk through it for this patient. So first, we need to determine, are we looking at the general population or a comorbid condition, and this patient does have diabetes. Next, regardless of age, all patients with diabetes have a blood pressure goal of less than 140 over 90. So this patient would not be considered at goal since his systolic pressures are above 140. Next, we need to look at race, and this patient is African American. Therefore, our preferred first-line agents would be either a thiazide-type diuretic or a calcium channel blocker in this patient. Case 2 is actually the identical patient, except I removed diabetes from the past medical history. Everything else has remained the same. So if we look at the algorithm for this patient, we again now would shift over to general population since there is no diabetes present. And now age does become a factor. So since the patient is over the age of 60, his blood pressure goal would actually be less than 150 over 90. So this patient would actually be at goal according to the algorithm since the removal of diabetes has occurred. Therefore, he would not require treatment at this time. For case number 3, again, this is the exact same patient except I replaced diabetes with chronic kidney disease. And if we look at the algorithm here, we can see all the way over to the right is where we're going to go with this patient. So regardless of age, all patients with CKD have a blood pressure goal of less than 140/90. And regardless of race, all patients with CKD should be initiated on an ACE inhibitor or ARB at some point. So again, based on the expert opinion, this might depend on the presence of proteinuria, whether or not we start with a calcium channel blocker and then add an ACE inhibitor, or if we start with an ACE inhibitor or ARB up front. The final case looks at a 42-year-old white female with a past medical history of hypertension and depression. And the clinician is wanting to know what this patient's blood pressure goal would be and what the first-line treatment options are. This patient, again, would fall under general population because she does not have diabetes or CKD. Since she is less than 60 years of age, her blood pressure goals would be less than 140/90. And since she is a non-Black patient, we could use any of the 4 first-line therapy options, whether it be a thiazide, calcium channel blocker, ACE inhibitor, or ARB. The last thing I briefly want to talk about are the guideline limitations of JNC8. And this has definitely been in the news recently about how the guidelines could be improved or possible literature that was overseen in the guidelines. So I just wanted to touch on this briefly. The first concern that I think people have is that there's little insight provided on various other comorbid conditions besides diabetes and CKD. So for example, patients with heart failure and/or coronary artery disease probably need to have a beta blocker or aldosterone antagonist added on board for mortality benefit prior to a calcium channel blocker, for example. So we would want to take into account the blood pressure reduction with those mortality benefiting agents prior to adding on the therapies presented in JNC8. So since they did not specifically talk about heart failure patients, this is definitely a limitation of the guidelines. Second, the data review for the development of these guidelines only really included randomized controlled trials. So there were observational studies, systematic reviews, and meta-analyses that were not taken into account when these recommendations were made. And while they're not as strong of evidence as randomized controlled trials, there are still important things we can gather from this type of data. Lastly, the final limitation I want to talk about is the controversy I've been talking about surrounding that first recommendation of a blood pressure goal of greater or less than 150/90 in patients over the age of 60. The controversy surrounding this recommendation really stems, so 5 out of 18 JNC8 panel members disagreed with this recommendation of less than 150/90 in this elderly patient population. And the reason they disagree is that they didn't really feel like there was evidence to support this high goal in patients who may be considered at higher risk for coronary artery disease or cardiovascular events. So Black patients, patients with previous CVD, other patients considered at high risk for CVD, these panel members did not feel it was appropriate to have this less strict blood pressure goal. The goal that was developed by the guidelines came from 2 studies, the JADOS and BALISH trials. And these trials also, while they offered some support in favor of the less strict goal, actually had some limitations to them as well, so definitely weak evidence. JADOS, for example, was looking at patients 65 to 85 years old, and they compared systolic pressures of less than 140 to systolic pressures of 140 to 160. And they actually found that there was a trend towards benefit in patients less than 75 years of age who had the stricter target. So JADOS, again, would show us that maybe our 60-year-old cutoff is not high enough for patients. And I think that's where some of the other society guidelines, such as the Canadian Hypertension Education Program, got their 80-year-old cutoff for their less strict recommendation. The BALISH trial also looked at elderly patients. So these patients were 70 to 84 years old, and they again compared a systolic pressure of less than 140 to a pressure of 140 to 149. And while they found no difference in the rate of outcomes, they also admit to this study being underpowered. So again, both of these studies do have some evidence supporting 150/90, but all the panel members were in agreement that this is weak evidence. Recently, there was a post-hoc analysis study published in the Journal of American Cardiology. And this study, which is from the INVEST trial, looked at patients, again, that would be considered at higher risk of cardiovascular disease or bad cardiovascular outcomes. And so patients over the age of 60 with CAD were enrolled in this trial, and they looked at patients who either achieved pressures less than 140 compared to systolic pressures of 140 to 149 compared to systolic pressures of greater than or equal to 150. And you can see in the figure to the right that when systolic pressures of less than 140 were compared to systolic pressures of greater than or equal to 150, this resulted in a decreased rate of primary outcome, all-cause mortality, cardiovascular mortality, MI, and stroke. So comparing the blue line on the figure there to the green line, you can see a significant difference between that and all three of the graphs represented. Next, when they compared systolic pressures of less than 140 to systolic pressures of 140 to 149, this study noted decreases in the rates of cardiovascular mortality and stroke in these two subgroups. So no significant difference in the primary outcome, but when we look at the two smaller graphs, looking at cardiovascular mortality and stroke, the differences between, again, the red line and the green line here were statistically significant. Therefore, this post hoc analysis, while not the best type of analysis to look at, does lead us to believe that there may be benefits in targeting a systolic pressure of less than 140 in these elderly patients. With that, I would like to thank you again for listening in today to this webinar presentation, and thanks to the Alumni Association for sponsoring it. And if you have any other content ideas, please feel free to email Stephanie Hoffman at the email address on the screen with those ideas, and we will look to getting someone to present those for you. If you guys have any questions now that I'm done, please feel free to type them and I will answer them to the best of my ability. All right, thanks again for joining us.